do, I want to welcome you and to do a land acknowledgement for the grand rounds for today. We'd like to acknowledge that we are meeting on the ancestral, traditional, and unceded territory of Musqueam people of this Coast Salish Nation. And I would also like to say that the rumor of Brown's demise is premature. It actually happened to the end of the term. So watch your inbox for announcements for upcoming rounds. In fact, I want to have a special call out for the rounds that are originally planned for March 27th, that will be showcasing some of our own students. We are really quite excited about seeing them. So with that, I would like to introduce today's speaker. Today's speaker actually is a team, and it's really quite exciting. And so you've already been introduced via the announcement to Eugenia and to Kirsten and to Heather, but they're going to also tell you about some very other exciting team members. And so with that, so that I don't cut into any more time, I'm going to turn it over to Eugenia.
Well, thank you very much. We are super excited to be here in our house to present on injectable opioid treatment, how safe supply of opioids fits within the continuum of care. To build on this presentation, I will have Kirsten and Heather, outstanding PhD candidates of this school, and also we are going to have some of our service users that are going to talk about what this treatment means actually for them. So injectable opioid treatment, a lot of evidence have come from this house. We have shown that is effective, that is cost effective. There are 2 medications right now based on the evidence that we have built in partnership with Providence Healthcare, with Palis, in this house, that can be prescribed. Now in Canada, we are expanded to 9 sites across the country. And before Kirsten, Heather, and I start talking about the evidence, we would like to hear. So everywhere we say, you have the service users' voices in your mind, what this means for them on what injectable treatment is. Thank you. Spike.
Hi everybody, my name is Spike. Thanks for having me out. When I ran across the Salome study, I'd been crushed in an accident, and although I'd made some reckless choices in life as a young person, but for the many years up to my accident, I was raising my son by myself, so I stopped making reckless lifestyle choices. But when I got crushed, it didn't matter at all anyway. The doctor that oversaw my admittance to Royal Columbian Hospital, because of my reckless choices in my past, he said that I was to get opioid analgesics for 3 days and absolutely nothing beyond that under any and all circumstances. I was in a coma for 5 days, but when I woke up, it was nothing pain. And our medical system treated me really poorly. And I'll just leave it at that. I saw, when I ran into Kurt the day that my name came up for Salome, I knew that it was positive, and it absolutely saved my life, nothing less. I don't think I would be here if it wasn't for Salome, if it wasn't for injectable opioid treatment. Yeah. Society must not only see us as human beings, they have to see us as a valuable piece of the human mosaic. Wouldn't the world be an ugly place if we were all the same? And until that value is seen, recognized, and appreciated on a grand scale, we are unfortunately fighting a war that we cannot win. Until that time, the funds necessary to address the epidemic that we're dealing with will not be allocated, and we'll continue with this march to death. I'm of the opinion that the day people started dying, they should have opened 2,000 spaces for opiate injectable treatment. That would be 2,000 more people that are alive, right? I'm the creator of the anti-stigma zone, and I've created that since I've come into Salome. I'm no longer on the injectable opioid treatment. By the way, 3 months ago, 2 months ago, I stopped, and yeah, now I take just oral Hadian, and that gets me through. So people can move away from it, but it was there when I needed it. I'm the.
Thank you.
My name's Daniel. If it wasn't for the IO program, I literally probably would be dead right now. I was up to an 8 ball a day of heroin before at my worst, and I had no hope or no idea what to do from there. I lost everybody close to me in my life, and I was out here by myself from Toronto. I found the IO program, and I got hope. It's the first time I've had hope in a long time. It's the first time I've been able to sleep in a long time. I used to have to wake up every day just to go feel normal, you know what I mean? And now thanks to this program, I have, well, I can sleep in. It's a big thing for me. and I can actually go about my day on a daily basis, like in a normal type of manner, without feeling like I have to go do something to get unsick or to get better. So this IO program saved my life, and that's all I have to say right now. Thank you.
Daniel received the treatment in Surrey, and the site that opens right after the expansion started. They have 40 spots, and they have been pushing, and they also prescribe both medications in Surrey. All right.
Hi. Hello everyone, my name is Aura and I go to Crosstown Clinic. I've been going there for over 8 years and I have similar stories as they have. But what I wanted to say was, since I've gotten into the program, I've since gained full-time employment. I've gotten back with my family. I went from 13 different medications to 2. I have absolutely no crime or any kind of shady activities going on at all. I also been in the program long enough to see that it needs to be tweaked slightly. I'm finding that travel is very difficult. I have relatives out of town, and I'm finding it very hard to mix the two together because I go to the clinic 3 times a day, and with my job, like it's really difficult, you know, to spread the time out. So I would like to see it branch out slightly, make it maybe available for emergency reasons from pharmacies, or best of all, see clinics right across Canada, or even North America for that matter. I can't say how beneficial this program would be, not only to the clients, but society in general. You know, people are dying out there and it's needless, right? I also, there was one more thing I wanted to say and I've forgotten now, so I'm just gonna leave it at that. And I hope that I've answered some of your questions, and if you have any more, just let me know. I'll be over there. Thank you.
Just a reminder that UBC is really far, and there is a lot of work for everybody to be here. So thank you so much for the outreach team, Anna, Kurt, that have made it possible for everybody to be here. And thank you so much for you guys to be here. And we will continue the conversation once we are done with what we have to say. So what more of the technical part, oh God, without glasses, what are the glasses? I think I can do this, but I do it. No, it's worse there. So, just always remember that maybe not everybody comes from the same background we come. So just a little bit background. When we think about opioid use disorder, or if you come from a different philosophy, think about heavy use, if you are not going to call it opioid disorder, tends to be a chronic relapsing condition. Usually because it's entangled with many other psychosocial determinants. It never is one thing alone. substitution treatment with long-acting opioids, such as oral methadone or Suboxone, works, and works very well. But not for everybody, and not all the time. For that reason, a range of options are required to meet clients' diverse needs. The UK has an addiction treatment system where medications like the ones we have tested here, that is the morphine, not hydromorphone, but also methadone, are part of the continuum of care. And you receive it in pharmacy and you can take it home. Switzerland started offering injectable diacetyl morphine in the 1990s, responding to what they call the heroin crisis, with young people injecting in the streets. But they did it in a very different way, because the Swiss are a bit different. So they did it in supervised settings. In this way, the rest of the community of clinicians and scientists that were willing to provide this kind of treatment felt that this would be an easier way to convince policymakers to provide this treatment. So this Swiss model was way more appealing and palatable to continue expanding. So when we think of IOT, and bear with the Spanglish, IOT delivery, we are going to think about core aspects on what is, how we deliver this. The medication is dispensed and self-administered by injection under the observation of nurses daily. So this is core. The medication is there. This is not very different from many other opioid agonist treatments where you receive the medication and you cannot take it with you. But this is very core. Observation daily. This observation ensures safety of the clients. If anything happens, we are there to support and help. And the community, because then you know where the medication is stored, who is using it, etc. I'm going to talk a bit about safety. For some, injectable diacetyl morphine and hydromorphone provide enough motivation to be engaged in so much needed structural care. This is rotation treatment. That is something that we want to provide from the healthcare system. The daily visits allow nurses and staff and clients to build relationships, build relationships with the clients. This is something that Kirsten is going to talk about a bit with her work during her PhD program. This approach to care provides a tremendous opportunity to offer comprehensive care, wraparound services and walk-around services, and to meet people where they are at. Heather is going to talk about what we are doing with the needs we are not meeting. So, if you're thinking, those are my hands, I'm holding 10 grams of heroin, and I didn't go to jail. So, if we're thinking how safe supply fits in the continuum of care, if we think of the definition of safe supply, we think of the Canadian Association of Safe Supply, or the Canadian Association of People That Use Drugs, and they say, well, safe supply is when you provide a legal version of something that people are using in the street. This is what we do regarding safe supply. We provide a legal version, diacetyl morphine, that is medical prescribed heroin, or hydromorphone. That is our aspect of safe supply. We have always done this for 20 years if you think of Europe. However, how we deliver it is treatment. We have always put people at the front of everything we have done. This is person-centered care, patient-centered care, client-centered care, depending on what is the trade you are sitting in. It's always about meeting people where they're at, and this is the healthcare system of providing care to people. So if we think about one of the key core aspects about is it safe? One of the things that before I tell you about safety, I want to ask you to think about compared to what? There are things I cannot compare to because I will never be able to do that design. Because I will never put people in the street because it will be unethical. But are we comparing people never using drugs compared to using injectables? Yes, of course. But are you comparing to using unsafe drugs that are not dosed by a physician? So of course, when you have the drugs used on-site, this absolutely minimizes the risks. The drugs are used on-site, and you have nurses, and you have staff, and there are people there to help. But we cannot avoid the fact that the intrinsic risk related to opioids are significant, and nobody is denying that. So those kind of things go together. So when we look at safety, we can go as far as when injectable hydromorphine and isomorphine are individually dosed and monitored, their opioid-related side effects, including potential fatal overdose, are safely mitigated and treated by healthcare providers. In other words, if something happens, we have been able to treat people there and nothing has gone further wrong. What kind of side effects we can expect? Well, you can expect from opioids, with some surprises between the hydromorphine and the diacetylmorphine. Somnolence and drowsiness, people just hold on a sip, and then the nurses go on, give them a hand, are you okay, do you need a hand? And local histamine reactions. This is important for adherence. If people are having really a hard time with the local histamine reactions, you're going to lose people in the treatment you're providing. Then, serious adverse events is an important aspect that will be mostly overdoses and seizures. The seizures we've seen have mostly been, none of them have been hydromorphine. We have 18 episode seizures and opioid overdoses. What was a surprise with the Salome study is that hydromorphine had way less adverse events by person, by number, than the diacetylmorphine. And when I say less, it looks that less. And this is just adverse events overdoses. So this is a busy table. I just want to pay attention to these numbers below. We published this paper because we were comparing overdoses that require Narcan during induction and after induction to see, because we have a rapid induction protocol to make sure we engage people in care rapidly. And I just want to make sure you pay attention to this. When we pull our 3 studies together, we have more than 500,000 injections and 73 overdoses that require Narcan. All of them safely mitigated by our healthcare providers. Thank you. Keep in mind the doses we provide. Dr. Scott McDonald reminds me that say that these are high doses is a stigmatizing way of talking about our clients. These are the right doses that our clients require. So, but keep in mind 261 for hydromorphine, 506 for diacetylmorphine, and this is the average, and it's halfway what our protocols allow us to do. Our protocols allow us to do 1,000 per day of diacetylmorphine and 500 for hydromorphine. This means we provide a safe and effective dose. Safe means what I just explained. And effective is about, do people feel as they want to feel with this medication? Are we reducing not just craving and not just withdrawal, but is this in the way you want to feel with the medication that we are providing you? With being so lucky that in these settings, you can actually choose what medication in shared decision making with the physician you are going to receive. Quickly, I just want you to pay attention that there is a high inter-individual variability in the dose. Means clients are going to sit in a very wide range of what dose they will need. This is very important for person-centered care. When you have this stigmatizing idea that persons that use drugs, they're going for the high dose, please have this chart in mind. We have a lot of clients that receive only 100 or 200. Yeah, we have some that are here, but they use the entire continuum of those. Can we retain clients into care? We have an 80% retention in the clinical trial. Of course, when this becomes a program, retention goes down. And this is data from our Crosstown clinic, and this goes down and down. And unfortunately, when we're not expanding in the way we would like to expand, we can look at the data from Europe. This is from Germany. If you look at this chart, the bigger one, at 12-month retention, they have 60% retention in injectable opioids treatment. Okay? What I want you to think is in the next slide. This is the data from Switzerland. Everybody in Europe has kind of the same retention, between 60 and 70% retention. Where do the clients go after you could not capture them with injectable opioids treatment? With the dark red, most of the clients are going to go to other kind of treatments, mostly oral agonist, methadone, and slow-release oral morphine. So I hope I convinced you that it's safe in the way we provide it. I convinced you that if you make this part of the continuum of care, you are going to be able to retain clients into care. And now we go to the third point, very important, about building relationship with the clients. Kirsten is going to help us to explain that part. Thank you.
Thank you for the introduction, and I also want to echo Eugenia's comments and thank the three of you for coming all this way and sharing your experience with us. So I have been, for my dissertation, exploring the concept of patient-centered care within injectable opioid agonist treatment. And I've done this through 2 studies. One has explored participants' experiences using qualitative methods, and the second study has been analyzing longitudinal trajectories of satisfaction with IOT. I'll be sharing findings from the first study, which was a qualitative study that followed a grounded theory approach. So I used 30 in-depth interviews with 14 women and 16 men who were receiving IOT. They were all, at the time of the study, receiving IOT at the Crosstown Clinic, and this was at the end of the Salome clinical trial, so people were receiving the treatment as part of regular care, not under the clinical trial framework. Sampling, data collection, and analysis were iterative, and this is consistent with the grounded theory approach. So what that means is initial interviews were very broad and open-ended, driven towards getting a sense of what participants' experiences were as it related to the medication, to attributes of the model of care that Eugenia has highlighted a little bit about. So what it's like to engage in a daily clinic setting, what it's like to interact with the healthcare providers. After about 14 interviews, a core concept began to emerge, and this was described as building healthcare provider relationships as being fundamental to other experiences of patient-centered care in this setting. And so after this concept started to emerge, the remaining interviews were devoted to trying to understand that concept specifically, what were its properties and its relationship with participants' initial goals and the outcomes that they were experiencing. So this is a figure that summarizes the main findings from this work. So on the left panel here, this describes the process of building healthcare provider relationships and why that was so important in this particular setting. And it reflects, I think, also some of the experiences that Spike and Aura and Daniel have also shared with you. On the left side, this was the second research question focusing on participants' initial treatment goals and how those were realized through this treatment setting. And its interrelationship with the process of building healthcare provider relationships. So participants described initially entering the environment of the clinic, needing to go through a process of opening themselves up, and that is italicized. Those are words that were used by participants, multiple participants in the study. So really, this I think reflects what Spike was saying, having had prior negative experiences in the healthcare system. Some clients had entered the environment with a bit of distrust in the healthcare providers. So there was a process in itself to learn to let their guards down, open themselves up to the healthcare providers. That really was rooted in the very basic features of the environment itself. So where they greeted every day with a warmth, friendly smile, and that helped to let some of those guards down and start to feel supported, accepted for who they were, and understood beyond just being an opiate user receiving this treatment. Opening myself up laid the foundation for opportunities to actually be a part of care, so to take more involvement actively in the way treatment was delivered. And participants here, again, this notion of feeling safe reflected again back those prior negative experiences. So after feeling accepted, supported, understood, clients could start to actually speak up about what it was that they were actually hoping to achieve, what kind of services they thought would best support that. It was also really important to be able to engage in respectful discussions where clients were given information in an unbiased manner and could then make informed choices and have some control or autonomy over their treatment planning. Moving through these processes, opening myself up and being a part of care ultimately allowed clients to receive individualized and holistic care that was tailored to their specific needs. And this mostly reflected two matters, which was finding a comfortable and effective dose. And Eugenia's slides, I think, speak to that quantitatively. We see that people are using the full spectrum of doses. But what the sort of novelty of this work shows is that in order to find that comfortable and effective dose, participants really wanted to engage in these respectful discussions with their healthcare provider to actually have some ability to share in that decision-making process. And then also receiving tailored and comprehensive care. While all those, there's a diversity of services available in this setting, what was more important for the clients that I interviewed at least was that they were offered in a very person-centered manner. So offered to me in terms of what is going on for me today. I'm not being forced to participate in all of these services. I can choose what I want to based on what I need today. So moving over to then the discovery of self-reported outcomes, the first initial goal that everybody had, and this was fairly unanimous across the 30 participants, was to reduce their street drug use. But the novelty of that finding again was in that in order to do this, participants really had to have found a comfortable and effective dose, and that meant engaging in respectful discussions with their healthcare providers. Also, the way the outcomes unraveled was very person-specific, so the narratives around that were very unique in the sense of the time, for example, that it took. Some people only needed a couple of weeks on a safe and comfortable dose to reduce their street drug use, while others it took a couple of years. So that helps to also give us a sense of why individualized and tailored services are very important in this setting. And then just to offer a few research and clinical implications from this work, for anybody who's delivering treatment for opiate use disorder, we think that these findings can also help guide some clinical practices and approaches there, in the sense that the findings really emphasize the importance of the therapeutic relationship in creating opportunities for shared decision-making, individualized and holistic care. Regarding the discovery of self-reported outcomes, so I didn't going through them all, but just to say that categorically or thematically, those do overlap with what we typically measure quantitatively in RCTs and observational studies. But the, again, novelty of this work was in finding that they unravel in a person-specific manner. We can't, as a healthcare system, expect that someone is going to reduce street drug use, that each person is going to have the same pattern, essentially, of reducing their street drug use. And again, that this was rooted in the therapeutic relationships. And then very lastly, there is a lot of interest among people who are delivering care for people with substance use disorders in trying to enhance the quality of care through efforts like patient-centered care or trauma-informed care, culturally safe care. And so these findings could also be applicable to those approaches. Again, demonstrating that the therapeutic relationships are fundamental to that effort.
So, safety, attention, building relationships, and now a tremendous opportunity to provide wraparound services, comprehensive care. There are so many needs that sometimes are not met. One of them is the co-use of stimulants. That's something from the addiction treatment system. It's very hard to meet because there is no very effective treatment to cope with in the community. So Heather has been working on our data to see what can be done, particularly from injectable opioid treatment, and she's going to share that with us.
Thank you. So I'm happy to be here today to talk about cocaine use in IOT. We know that rates of cocaine use in patients receiving injectable opioid agonist treatment are quite high. So at the Salome study, at baseline, about 3/4 of participants had reported cocaine use. About 1/3 of them were using cocaine every day, and this is similar to what's been seen in Europe as well. We know that this is potentially concerning because people that use cocaine, both in oral methadone as well as in IOT settings, are known to have overall poorer treatment retention and higher rates of street opioid use. Reductions in cocaine use are modest in IOT, and that's because this is a treatment that is meant for opioid use, and it's not specifically meant for stimulant use. But we have an opportunity to look at understanding cocaine use in our data because we have collected data over both the Salome clinical trial and a cohort study that followed. And so in the past, really the focus has just been on cocaine as a secondary outcome in clinical trials, and so we haven't really looked beyond understanding the change in the number of days of use. So over this longer period of time, we now have 48 months of data from those two studies, And we can see that most of the decline that happens in cocaine use is in the beginning of the study, in the first 3 or 6 months, but that reductions do continue over time at a little bit of a slower rate. And if we want to really understand what's going on, we can look beyond the population level average and look at individual trajectories over time. So each of those gray lines there represents a different study participant, and you can see that there are variations both within people and between people. So people are changing in their own use over time, but there are also differences in terms of where people start. So the intercept at time 0, you can see people are at different places, and then the rate of change is different across different people as well. So we can use what's called a multi-level modeling approach to try to understand and explain variations in cocaine use both at the within-person level and at the between-person level. So I'm going to walk you through a few of the models that I've been working on in order to describe those variations. The first model that you'll see here really is just meant to show that there is significant variation both at the within-person level and the between-person level. So all that's entered in this model is just the outcome of cocaine use. That tells us that we now can move on to trying to add different variables to the model to explain those variations. So because this data is measured over time, the first variable that's added here is the time effect. And you can see that that is statistically significant. So that means that for every month that elapses since baseline, participants are significantly reducing their cocaine use. And that's helping to explain some of the within-person effect. So really what we're looking for here under the random effects is that the numbers are decreasing as we add variables to the model. If we want to look at understanding the between-person effect, so why some people have higher use than others, what we can do is add variables that don't change at the within-person level. So things like gender or somebody's fixed age when they enter treatment. And you can see that both of those are statistically significant. So in our population, women do use significantly more cocaine than men, and as people get older, their cocaine use is also increasing, or the older people in the sample have higher rates of use. You can see again that the between-person effect here is decreasing. So the number for model 3 at the between-person level is going down, meaning that we're explaining some of the between-person variation in cocaine use with adding those variables. One of the key variables that we're interested in is treatment engagement. So in model 4, we've added a variable that reflects the number of days that a participant is receiving iode. You can see that that's a statistically significant effect. So for every additional day someone is receiving treatment in the prior month, their cocaine use is significantly decreasing. Here you can see that numbers for both within and between person variation are reduced, but we might have the hypothesis that there is more to explain there. And one thing that these models allow is for the splitting apart of between and within person effects at our predictor or explanatory variables. So right now we're assuming that the effect of being in treatment is the same for the within person level and the between person level. In model 5, we can split those effects apart, and you'll see that those are actually both significant. So at the within person level, what that means is that for each additional day that someone is in treatment, their cocaine use is being reduced. The between person level means that for every additional day someone is in treatment as compared to the overall population mean, their cocaine use is being reduced as well. And we know that this model is doing a better job at explaining variation. You can see that the between person effect is significantly reduced there as well. So we could have looked at adding any sorts of variables to this model, and I have explored some other variables, but today I wanted to show a model with treatment engagement, just to show that being engaged in iode is associated with reduced cocaine use. We do see, however, in the plots that I showed before, that people are still using cocaine in this sample, and so we want to think about what else we can do to support them. So up until very recently, there had not been very much success in studying pharmacological replacement for stimulant use. So we're definitely not at the state that we're at for treatments with opioid use, for opioid use disorder, but there is a trial from the Netherlands that was conducted in a setting that is very similar to the Crosstown Clinic. And they found that among their patients that were using cocaine, if they prescribed Excedrin, the patients actually significantly reduced their cocaine use and their craving for cocaine. Dexedrine is licensed here for the treatment of ADHD and for narcolepsy. So following that evidence, our clinical team at Crosstown started to prescribe to patients and saw similar positive effects. And we've been working on a knowledge translation challenge project with Providence Healthcare to try to promote the practice of Dexedrine prescribing. One of the things that we're seeing in sharing this information is that physicians in other provinces like Alberta and in Eastern Canada have now started to prescribe this to their patients. We know that this does work very well for some people, but it doesn't work for everyone, so it's really just one opportunity to offer support, and there's still definitely a lot of work to be done here. Thank you.
So we are closing, and before I say moving forward, how proud I am of my students. Amazing work. So the last 2 slides, moving forward. The response from the system continues to be lukewarm. The positive findings have not yet in general pursued policymakers to support IOT, not in general to roll out the treatment in the way we would like to see it. We still, you know, Spike, I am amazed. I don't know, do you read the data I read because I dedicate my life to this and you know the number? That's the exact number, actually, if you look at European data, the number that we should aspire to get, 2,000 to 3,000 more spots in BC. If we look at Europe, this would be 10–15% of the treatment offered on opioid agonist treatment. So, even in countries like Switzerland, where we all look up to, the potential for, they call it heroin-assisted treatment, is only partially deployed. I use their language because they took a slide from them, due to political reasons, drug policy, restriction, and federal law. Unless we keep pushing for changes in our drug policy and decriminalization, we are going to get stuck. So those 2 things have to go in parallel. So from this humble team, where we continue on our advocacy and pushing for many alternatives for treatments, what we are doing, we try to improve treatment uptake. So we are working on applying methodologies that can recognize the profound diversity of our clients. If you think of the work that Kirsten was presenting and how important is safety and feeling safe when you come to a place, just think about, you know, people that face you know, systemic racism. How does it look like? So definitely we will have to incorporate indigenous worldviews in our methodologies to be able to capture how the system needs to reach people with those particular experiences. We are to conduct person-centered research and improve how we measure outcomes that clients care about. We are working, you know, with Adam and how we bring important and robust methodology from social sciences so we can capture these differences and we can go back to policymakers and tell them, for example, nominal group techniques and things like that. Quantify patient preferences to identify what matters. We are working with Nick Vansbach and we are doing best for scaling and our PhD students, also from here, Rebecca, doing very exciting work to be able to tell policymakers what clients care about the care that is provided to them with quantitative methodologies. And we are developing theoretical framework of the nurse-client therapeutic relationship with Michaela, that she is leading, she's a medical anthropologist, and she's leading that work, working with strong leadership, nurse leadership in BC to come with theoretical frameworks to support this work, because this is a very nurse-driven program. And I cannot believe that we have done this in 40 minutes as we planned. I'm amazed. So, we're done and we are all the questions, please, to Martisha.
Thanks.
Stefan, is this mic okay for the, okay, great.
Fine.
I would like to invite questions to any of our speakers today, and I would like to particularly hold off on faculty until students have had a first chance of being able to ask questions. I'm only going to hold that open for a minute. Okay? In that case, I am going to open the floor for questions to our speakers today, please. And I'm going to be running around with this mic so that we can capture it on our screen.
Thank you all for a very moving presentation, really very. And thank you especially to the team for coming and sharing your stories. I was just wondering if you could speak to the question of how important it is to have the stories of your participants in this program and how effective they are in helping you with the advocacy part of this work.
The stories of the participants. Well, thank you for the question. It has been always very important. I'm looking at the team because the story of the participants is building has always been the core, and at the beginning was from a clinical trial. That was not part of the methodologies, because the clinical trial is meant to show effectiveness of a treatment. So there is not much space for funding for that aspect. So in the beginning, Kurt was collecting letters from the clients, and we were doing our work with the media and collecting the stories. Providence Healthcare was fundamental on the support from the media team, on bringing those stories and the clients advocating for themselves and building from there. Once we were able to show that it was effective, and we were able to apply for different kind of grants, and as I said, once the boring questions like, is this effective, yes or no, we could go for more complex questions, because clinical trials go for questions that are black and white, and then you can go for all the questions that are a bit more complex, and that allows you, you know, and I'm looking at Adam and says yes, and we spend hours expanding. The stories are key and they're fundamental, and we are bringing students that have these fantastic ways of making this inquire. How we bring these stories are very important, and mixing not just the story itself, but it also, how can also make these numbers in numbers so the policymakers can also see it. So we are working very hard to make sure we have the right methodologies to bring all the stories into place, because they are so fundamental that we don't come without them to tell the stories. So thank you.
More questions? Yes.
Eugenia, I know that you have a number of papers with Nick and Bodan on the economic side, and obviously Aslam's involved as well. Do you have any thoughts on whether, just picking up on Susan's point in terms of policy and advocacy and changing policy, have you had any update from the health economics aspects showing like what looks to me to be treatment being more favorable and cost saving, or significantly cost saving, in part according to some of the work around decreased criminality? Is there any uptake on that front with respect to the cost effectiveness studies?
Well, we have shown it's cost effective. We have shown that it saves from the societal. I mean, I don't want to. You were the lead on that. It does save the system. But we always go to the same place. Policymakers doesn't seem to be willing to roll this out in the way. I mean, Martin, do you?
Yeah, let me say one thing.
Yeah, please go for it. Because
So
that's the reason we come in a team, because everybody wants has something very important to say.
So as you pointed out, the paper that Nick led with Aslam and others and our team showed cost effectiveness. The Dutch had previously looked at their study and showed cost effectiveness. Now, there are people running around this province. Some of them are faculty members in this school who are saying the words, "it's not scalable." Okay? What that is code for is we're too cheap to pay for this, even though we are otherwise intelligent people who understand what the word cost effectiveness means. But no, it's not scalable because we're too cheap. Now, there are different models that Eugenia can talk about how to deliver this in a less expensive way, but it's all about money. Don't pity.
Sure, you have it.
Yeah,
Go ahead.
Hi. That was great, and I think the work that come out of this is like, you know, really set the stage for the whole discussion about a safe supply. But I think it would be interesting to have the discussion about a comprehensive wraparound clinical care for people who have opioid use disorder versus a public health approach to the overdose epidemic and crisis where 5,000 people have died in the last 3.5 years in the province. So I think that, you know, commenting a little bit on Marty's thing, I mean, we have to have a bunch of things out there that are rapidly allow people access to a safe supply of drugs, which may be a little bit at odds with a comprehensive wraparound person by person thing. So the stories that I've heard for 10 years, people like Spike, I mean, this is what people deserve. But how we can get people just ethical access to a rapid, safe supply and not be so concerned about clinical care and wraparound services. Because we're in an emergency situation where in my mind, the scalability isn't so much to do with cost, it's how we practically get safe drugs out there in a big hurry and not be so concerned with wraparound services and clinical care. Because if we had a poisoning epidemic of any other thing, we would not devise programs that are individually focused one-on-one to engage people. So we really need a whole scale of things, but the program I'm working on, just get hydromorphone out there as quickly as we can, because ethically, people who are not engaged in these comprehensive programs have no alternatives. It's basically either get in those programs, which are very difficult because of scale up, or we just wait. And we've waited for 4 years, and people just keep dying. And the chance of overdosing today in Vancouver is probably higher than it was 4 years ago. Like the drugs are worse now. So we've done a great job of maybe getting people reversed. So we've saved a lot of lives through naloxone programs and overdose prevention sites. We're slowly getting more people involved in these injectable programs, but we really need to, I think approach this as a poisoning epidemic and how we flood the scene with safer drugs for people.
So, just one of the things to, sorry? Yeah. So one of the things is, and very quickly, it's not versus. When you said versus, it's not versus. We need everything.
Yeah.
Just to start, we need everything. The work that is done in these clinics, we need, as Spike said, 2,000 more spots, and we need to reach another 1,000 of people that this treatment is not going to reach. This treatment was never meant to solve any crisis. It's always meant to be and serving a small role in the addiction treatment system. But we are not using it. Can I be more clear? We are not using a safe and effective treatment that has been here in Canada for years. The ministry is not rolling it out. We should be doing it, and we should also be doing more public health, because this is not going to reach everybody. Absolutely in agreement, but it's never versus. We need everything. So
I apologize if I came across as person. So I do recognize that we just need a whole bunch of stuff out there first.
It doesn't have to be one or the other. There are so many people out there that are in need of safe supply. And we had this conversation like 2 years ago, and there has to be more spaces available for this, and there has to be other options. But this is proven to work. I don't think it's, I think it's hatred is what it is. It's stigma. It's because that we're drug users, right? And so we're not seen as people with any value, and that's the unfortunate reality. It's hatred, and you need to address it out.
Yeah, I just wanted to say that I think the argument has to be changed a little bit to get the policymakers to react and scale up. It's because they have been focusing on the fact that they can only deal with a small portion of the opioid overdose crisis by providing safe supply. But the argument should be the spillover benefits, because the number of people who are dying who are not regular opioid users has now become so large that providing this will have huge spillover benefits, and I think that's the way the argument may be more successful. And I don't know how we start that argument, but basically it's middle-aged construction workers. If you look at the latest statistics, the proportion of people who are dying, they're not regular users. And if the politicians knew they could reach everybody that way, then it would, I think, spur them off.
Thank you.
So thanks. I wanted to ask a little more about the politics.
Wasn't knowing this about
Well, my question is, has anyone tried to do a more comprehensive political analysis of what the policymakers think about, care about, and thinking about a political change strategy? Because there are many examples in public health of issues that were political non-starters, and sometimes there have been successful strategies to change that, sometimes not. So I wonder in this province or with this issue, whether anyone has been working on that.
I just said they talk, we die.
Yeah.
Right?
Well,
I think there's been enough, and there have been enough studies, there have been enough conversation, like let's save some lives, right?
I would say that one of the strategies we've adopted is called science. Which is, in 2003, when we started Naomi, this was a non-starter. Then we did a randomized control trial published in the New England Journal, and you go to a politician and you show that to them and they go, oh, science, evidence, right? And I'll be quite honest, this whole interlude of providing this as a treatment is what's the word? It's an interregnum period before legalization. Because I can tell you, as sure as I'm sitting here, there will be regulation of drugs someday. As sure as the sun will come, well, it won't come out in Vancouver, but it is going to happen. The question for you guys and politicians is, which side of history do you want to be on? And Mark's right, this alone is not. Regulation is going to happen, and it's just a question of when. Using science and medical treatment is the advocacy route to even begin to talk about that. And that's what this was all about. So the question is when.
When we have worked so closely with Health Canada and have been such a great partner, particularly the people that do the work, not the people that make political decisions. When I was in a meeting with them, and of course I can't say the names because all this is confidential, one of the persons said to me the day, what's the name of our Prime Minister now? Trudeau, thank you. The day, yes, oh sorry, I was just like, I'm very bad with names. Sometimes I don't remember the names of my own family. The day Trudeau won, she said, immediately I was in bed with my husband and immediately I told him, oh, we will have to give them the heroin now. That's how much we have been working with people that are aligned philosophically with us. The work that we have been trying to do behind the scenes, but at some point we are handcuffed with prohibition.
Yeah.
Well, like this. Follow up on Marty's thing, how this starts. When you look at the microcosm of Vancouver as sort of the innovators, when I came in '98, it was a one-to-one needle exchange. That was the big thing to try to get people clean needles, and now we give people boxes of needles. The Insight was the only place open for 12 years before 2016, and now we have 30 of them. So the safe supply discussion as a response to the overdose crisis hadn't really started very much until 3 or 4 years ago, and now everybody's talking about it. So I mean, the dial is moving, but if we can learn any lessons from innovation and getting things going, it was always at the community level that they just did it. And in some ways, crosstowns just did it. So, and the politicians and policymakers respond when the evidence and momentum gets so great they can't say no. So we need to, people just need to have some guts and just move on this, and the politicians will have to react because they act inside just trying to convince people on a 4-year cycle that they should do something dramatic is really difficult. And so just to do it, and then they have to respond.
Good people break bad laws.
I was actually wondering about the compliance. How is it like do you take any steps to maintain their compliance with the therapy or something like? Because like one of them said that they have to make at least 3 visits to the clinic. I mean, does it lead to any non-compliance or something like that?
We have to go up to 3 times a day at my clinic. If you miss 3 days in a row, they cut your dose, a portion. If you miss 3 months in a row, they start looking for other options for you. And as far as drug use on the street goes, they do urine analysis once a month for me. It varies depending on the client and what's shown up in their urine prior. But if they're using on the streets, they don't get penalized for it. It's only to make sure that their dose is going to affect them safely. If there's alcohol or benzos on board, they have to be a little cautious. Some people have to give a blood breathalyzer prior to the dose to see where their blood alcohol level is at. But yeah.
Can I answer the question?
Yeah, I was just wondering, do you actually take any steps to maintain the compliance? Is there anything that you have integrated within this whole?
It's not prison, I just want to point that out. It's not prison, it shouldn't be prison, right? It should be healthcare, right?
Yes, exactly.
It's different for every individual case, right? It depends on what you plan with your health practitioner, it depends on the overall outcome of the So I have a 5-year plan with my doctor, so I'm almost 2 years into it. So there's regular urine screens by my design, right? So it really depends on the individual and the doctor. Does that help?
I think they're far too worried about the rules and compliance and even diversion. Because you know what? If some heroin ever made it out to the street, it would be healthy. A healthy dose that's not going to kill anybody. But the poison that's out there right now.
I just wanted to say that in the over 8 years that I've been in the program, I've only missed a few doses, and I haven't used street drugs at all. And no one ever told me not to. I just, did that choice on my own. And I also went from taking the maximum allowed, and now I'm only taking maybe 2/3 or less of what I was taking when I got into the program.
And we're not all broken. That's very important. We're not all broken. You know what? Some people just like to. People use drugs everywhere. Not everybody will admit to it. People, I'm sure a lot of people in this room have tried and won't admit to it. But that's because of the way our society is, and that's because of prohibition. That's because of stigma. Sometimes humanity likes to run away from itself for a minute, and you know what? Freedom of choice. I should be okay. If I want to get loaded, I should be able to get loaded. We live in a free country, right?
Unfortunately, we are going to have to wrap this session up, and I want to thank everybody, the whole team. Because, as often happens, researchers have a whole team behind them, and it was wonderful to see some of the team. Thank you so much for that. And if we could thank our speakers.